Well, good afternoon, everyone, and thank you for joining us to a webinar featuring the Trusted Exchange Framework and Common Agreement QHIN Technical Framework. Today, you're going to have an overview of the QHIN Technical Framework, or the QTF. Joining me today is Alan Swenson. He's the Executive Director of Carrier Quality and has been the lead on the QTF work, along with David Pike, who's really done a lot of most of the legwork on the implementation guide here, the QTF, and representing Audacious Inquiry. If you go to the next slide, I just want to mention that this is actually, this program today is actually part of the first part of the ONC annual meeting that is taking place today and tomorrow, with the second part following in April. But we're really here today in our role as the recognized coordinating entity working with the ONC under a cooperative agreement. We really are just so honored to have had an opportunity to work with the team. They're just great to work with, as you can imagine. And so anything we're presenting today is really not an official position of the government, but really a reflection of our work. So let's go to the next slide, talk about the agenda where we're going to cover today. And we know we have a large audience and anticipate there'll be lots of questions. So we're going to do a quick recap of the components of the TEFCA. Again, we're drilling down today on one of them, which is the QTF, and provide a little bit of context around that. But really, we're going to spend the lion's share of the day delving into the details of the technical elements of the TEFCA, getting into workflows, the functional and technical requirements needed to support the exchange, and then talking about how TEFCA will be operationalized. This is intended to be, an opportunity for you to have your questions addressed. So we do encourage you to please type your questions in the chat function. We'll leave plenty of time at the end as well. And we, like I said, I'm seeing that we have quite a large group today. And so we may, if we are not able to get to everyone's questions, then we'll certainly be hosting additional forums. I think we're actually going to be hosting office hours. So, plenty of opportunity on that front. So without further ado, I'd like to turn it over to Alan Swenson to get us kicked off here on the drill down. Alan.
Perfect, thanks, Marianne. And I will just turn on my camera here briefly to say hi to everybody. And then I'll turn it back off so you can have your full screen for the slides. But I did put on a dress shirt today so that I was dressed up for presenting. Hey, and Dave Pike has one on as well. Perfect. I'm not wearing any shoes though, so the pleasures of webinars. So we will, as Marianne said, we're actually getting probably pretty close to the limit. So those who joined right on time are going to be in, and others may not actually be able to join us today. We'll see how high capacity gets, but glad to have a huge group of attendees here today as we're going to be going through the QHIN technical framework. We'll give I guess a quick overview of what the QHIN technical framework is, what it is that we're talking about. And then the intention largely is to go through the document itself. Well, not actually pulling up the document, but section by section as the document is broken down. So for those who participated in the webinar that we did over the summer with draft 2, this is going to be a very similar structure going section by section. But let's before we get into that, let's just talk about again the components here and where the QHIN technical framework falls in and what it is that we're talking about. So there are a number of components. Many of these were released recently, and with certainly more to come, including the Trusted Exchange Framework, the Common Agreement, several of the initial standard operating procedures. If you're interested in those, there was a Common Agreement webinar that was done last week, and there's another one as part of the ONC meeting tomorrow that you should certainly take a look at registering for to attend in that. Looking at some of the details specifically of the Common Agreement and some of the initial standard operating procedures. QHIN onboarding is more details to come on that as far as the process for QHINs applying and going through the onboarding process, some of the metrics for reporting and then governing approach. Lots more to come, including additional webinars. Today's focus, as indicated on the slide, is really this one right in the middle, the QHIN technical framework. So what is the QHIN technical framework? Or the QTF. This is the document that outlines essentially the technical requirements and all of the conformance statements that QHINs have to be able to meet in order to ensure QHIN to QHIN connectivity and that QHINs are able to communicate with all other QHINs. We point to a number of industry standards and we'll continue to expand from there, and then we build additional constraints and clarifications to ensure that everyone is doing it the same way. Most of what is in the QTF is QHIN to QHIN. So I would expect that most who are attending today, this is certainly good information to know what is expected of QHINs. But unless you're going to be a QHIN yourself, what flows down to a participant or sub-participant is likely going to vary by how the QHIN manages things, and we'll talk about some of that in the specific requirements. There are some requirements that do flow down to participants and sub-participants just to ensure that things are consistent across everyone participating, but for the most part, the requirements that we're talking about here are QHIN to QHIN requirements. The onboarding designation will certainly go along with this because it will tie into what's required and some of the timelines. We're not going to get into a whole lot of details of this one today, but there's more information to come. And this will outline the onboarding and designation process. Will include all of the eligibility criteria or more detail on the eligibility criteria. The criteria themselves are included in the common agreement. So certainly take a look at that if you're potentially considering becoming a QHIN or applying to become a QHIN. Take a look at the common agreement for the eligibility criteria and more details to come on that as we flesh out and publish what that onboarding process will look like. The timeline, again, lots more details available in some of the other webinars about overall, but we're here in Q1 2022, already February 2022, which seems crazy, and it's Groundhog's Day. I neglected that at the beginning. Happy Groundhog's Day to those celebrating this often underappreciated holiday. We are in the process of finalizing a lot of those documents. Expect to see QHINs beginning to apply in Q2, and then onboarding throughout Q3 and Q4, and some exchange beginning to happen sometime around then, depending on when everybody gets through the onboarding process to move into production. So that's where we're at today, and lots of exciting stuff to come over the rest of this year and into next year. So let's get into the technical details. And again, just kind of overview of some of what's included in here, and then Dave and I will go through a breakdown of some of the specific sections throughout the QTF. Hopefully everybody had a chance to read it before you joined. It's only 36 pages long. If you participated in the webinar over the summer, it was 42 pages long then. So in finalizing this, we actually eliminated 6 pages, which was nice. And I see some questions already coming in. Just a reminder, if you have questions as we're going through all of the detail here, please put those in the question window. We may have some time to also, if people would prefer, raise your hand and unmute for questions. We'll see what time's looking like for questions at the end. We'll likely address questions on individual specific sections as we're going through those. So put your questions in as you have them, and as we're going section by section, we can address some of those questions real time, and then we'll see how much time we have at the end for addressing as many of the rest of the questions as we can get through. But the QHIN technical framework has several components. It outlines information flows for patient discovery, a document query, which includes 2 transactions, both the query and the retrieve, and then message delivery. It's expected that we'll be exchanging mostly CCDA 2.1 documents, and then there are a number of functions and technology listed, and again, these are all the sections that we'll be going through section by section, so I don't need to spend a whole lot of time here right now, but this is kind of an overview of everything that's included in the QHIN technical framework. So 2 exchange modalities that we're starting with, and those are query and message delivery. And the 2 were, make a whole lot of sense to include together. They're often referred to as push and pull. Received a lot of feedback about the importance for the 2 to be used together, and we already see in the industry today a lot of use of the 2 together, where you receive pushed information that doesn't have everything that you need, so you turn around and use a query to go ask for additional information, or vice versa, leveraging both the push and the pull functionality together. And so having both of those in a single framework makes a lot of sense. Now, as far as what those look like, a flow diagram here, starting with query. So the query transaction, and for those who aren't familiar with what this looks like, is completed in 3 steps. And the standards that are used are listed there in the middle: the IHE XCPD, ITI 55, followed by the XCA query, the ITI 38, and then the XCA retrieve, the ITI 39. Now, the important part here, again, for many on the call, are those standards are required at the QHIN level. And there could be any number of hops, as you see on the slides here, any number of hops between the query source getting up to the QHIN, and there could also be any number of different standards that are used to get there. If you have an HIE, for example, that already supports an XDSB query or some other method, PIX queries instead of doing an XCPD, that is still perfectly acceptable and would be translated by the QHIN into the appropriate XCPD or XCA query and retrieve when communicating with another QHIN. So again, going back to this is defining how QHINs have to talk to each other to ensure that there's the communication across QHINs. But we, for a lot of these, especially with the standards, don't define what has to be used within a QHIN and its participants and sub-participants, as long as the QHIN is able to handle the appropriate translation. So even, the use of FHIR within a QHIN that gets translated to the IHE standard profile, proprietary APIs, I expect we'll see some QHINs that are offering that for their customers. But ultimately, it follows this three-step process through some communication mechanism. The query source communicates up to the QHIN the patient information that it's looking for records on, the demographic information. That may include a known outside source that needs to be queried, or it could say, we don't know where this patient has records, and we just need to query the whole community and find out where this patient has records. The QHIN would translate that into an IHE XCPD query to the other appropriate QHIN or QHINs as needed, who would then determine a patient match, and we'll get to some of where and how that happens, whether it's the QHIN or they pass things down, and return back a patient match response. In the case that a match is found, that response includes the patient identifier and assigning authority ID, which are used in the subsequent XCA query asking for this known patient ID. What documents do you have available? The XCA query returns back a list of available documents. From that list, the query source would be able to choose which documents to retrieve, whether that's one or a subset or all of them. Those would then be subsequent XCA retrieve transactions to go get those specific documents. Some of the requirements on the patient discovery, the first step in the query flow, are the inclusion of, we do have some requirements, and this flows all the way down to participants and sub-participants around the demographics that need to be included. And this is to ensure that the responding side gets all of the available demographics to be able to make an appropriate match. Conversion to XCPD, we already talked about that. A patient discovery responses, including the responding sources, identifiers. Again, that's part of how you know who has the information and how to send that subsequent one. Now, one of the things that changed in the final version from the draft is we do actually now point to the Project USA technical specifications for patient address demographics. Previously, we were proposing USPS, but Project USA specification was finalized before we finalized this, and so we were able to point to it. So that is one change that you will see from the previous draft version. And this is a requirement at the QHIN level. A participant or sub-participant certainly could send the properly formatted demographics using the Project USA standard, but if they don't, the QHIN would need to convert the address before sending the XCPD query to other QHINs. And let's pause there and see what questions we've got, or Dave, if you've got additional context on just the query piece, before I think we'll jump into some of the requirements for doc query and retrieve.
Yeah, the query is straightforward. An XCPD query is fairly basic. There were a few things added after comments, one of which is when you receive a query for patient data, you respond with patient data from the responding source. not the information that was provided in the query. That way it can be verified. But in general, it's a straightforward query using information. We do have a number of questions popping up.
Yeah, a good number coming through. There's some, I'm just looking through because there's some questions around authentication, which we'll get into in the authentication requirements section, certificates, which we'll get into. Patient identifier, so here's one that applies directly to the topic here. Is the patient identifier unique to the patient regardless of the QHIN? This is not a national patient ID, but this would be an identifier that is unique within the context of whoever is responding. So it comes as a pair, or actually as a triplet. It's the patient identifier, and you have to know the assigning authority that identifier comes from, and then the home community that assigning authority is part of. Altogether, that gives you a globally unique identifier that tells you what is the patient's identifier and where does that identifier exist. The identifier itself is not necessarily unique and theoretically could exist multiple places if multiple assigning authorities have the same identifier creation logic. So it's not a complete national patient identifier per se. It's not necessarily going to identify the patient anywhere, but for that specific responding source, it will uniquely identify the patient. But a given patient would have a unique patient ID, assigning authority ID, home community pair for every source that has information about the patient.
Molly Murray asked this question. You mentioned passing along a patient ID as part of the query. Is there an expectation that the, whoops, it jumped. QHIN have a shared record of patient IDs to refer against? That goes right down to whether QHINs will maintain an MPI or RLS, or if they're federating the query. And the short answer is it depends on the QHIN. We do suggest that in order to meet SLA, that QHIN does maintain a master patient index, enterprise master patient index, so that they can respond to queries much faster. However, it is quite possible that they can do that through a federated query, which means if they can do it in the time permitted, they simply query all of their participants saying who's got information, and then they can present that as the response to their query as well. So the answer is maybe.
Great. Another question here, which demographics are used for matching and what standard of confidence is required? The short answer is that we don't specify the algorithm that must be used to make that patient match. We specify demographics that need to be sent and the format of some of those demographics, such as the physical address. But the matching itself is going to be determined by the algorithm of the responding organization. That is absolutely something that we recognize as we get QHINs established, participants and sub-participants exchanging. We're going to want to do some work and see where we can make improvements across the board with demographics-based patient matching. But today, we put in place requirements to ensure that there are sufficient demographics that can be understood for matching, but leave the algorithm itself to the responding side.
All right. We have two questions regarding the USA project. One is asking for justification and one asking for where they can get the specification. Why did we choose that over USPS publication 28? Well, quite frankly, because it's specific to the healthcare IT industry and to patient matching. So many of the things taken into account for the USA project, sorry, my habit is to call it USAT because that's how it's spelled. USA projects are specific to enhance and patient matching. So we are looking for that. Where you can get it through the ONC website. I'm sure that somebody can dig up the full URL, but if you go to the healthit.gov site, type in USAT into the search bar, that will get you there faster than we can type it.
It's also referenced specifically, the same website would be referenced in the QTF. If you pull open the QTF and just search for the first time we reference the Project USA standard, there's a footnote that links to where that's housed.
Sorry, I'm reading through John Kelly's question regarding fire. Have we built enough minimum requisite maps to understand that if we have the fleet translations? I'm not at all sure how to answer that question.
Well, I think the short answer is we don't define what standards a QHIN can or even should use within its own network. The QHIN has requirements to use XCPD and XCA when we're talking about the query flow here. And so the QHIN would need to establish with its participants what information is required in whatever technical method it uses to ensure that the QHIN can appropriately create that XCPD XCA. We do not specify the standards that are used within the QHIN or how to map them to XCPD XCA, but that is pretty common already in the industry today. Within Carry Quality and Commonwealth and others, there are organizations who provide gateway services to other vendors behind them and use other standards, even proprietary APIs that they translate to the appropriate standard for communicating with others. And so this does have precedent already in how a lot of organizations exchange in the industry today.
Great.
A question here about zip codes, zip +4, and whether that's required. And the short answer is that the standard doesn't require the +4. Whether a receiving organization uses or ignores the +4 would really be just based on their algorithm.
All right. Lots of questions here. Wouldn't a QHIN have to crack open a message, convert the demographics to USA specification? No. We're expecting, and one of the flow down requirements is that it is done at the source or on the way to the QHIN if necessary. The QHIN itself will validate that it is USA appropriate and only convert it on then. However, again, this is for patient matching, so it was just the query information, not patient documentation. So none of the health information or the TEFCA information that is flowing through would be checked. Only matches for patient identifiers so that they can be easily matched at the far end.
Great. And Dave, there was a comment here. If you could move closer to your microphone or wherever, however it is that you're going, there was a comment here about just being able to hear you. And that may just be on the side of whoever it was that made that comment. But maybe one more question. I see lots of questions coming in. One more here, and then we need to keep going, and we'll circle back on others at the end. But a question here: if we intend to require identifiers received in an XCPD response to persist, because there is a comment in the QTF about if the patient identifier and responding source are already known, the patient discovery phase can be omitted. And the short answer is that we don't require that the identifiers persist, but we know that they often do, depending on the responding source and how they manage that within their own system. This is in line with how we do things in Carry Quality and how other networks do it. So there is a standard response already defined. If you send a query and for a patient identifier and that patient identifier is no longer recognized, there's a standard response that tells you this patient ID isn't known, try again with demographics. And so that is what would likely be expected here, is you would persist the identifier until you're told the identifier no longer exists and you need to start over. But there's not a requirement to persist them. So let's move forward here. We're still in the query flow. Though some of these questions there's some things here that we probably already talked about as well. So document query and retrieve, again, we walked through the flow there. It uses the ITI 38 and 39 transactions, QHIN to QHIN. And the one thing that is important to call out here that we changed from the draft is responding QHINs may convert documents to CCDA 2.1. And that is important. There was previously some proposal around requiring conversion to CCDA 2.1, and there were a lot of great feedback that we received and concerns around some scenarios where that really doesn't make sense. And so that was updated to a may. QHIN can certainly work with its participants and sub-participants on what formats they expect to be able to receive and what formats they are able to generate to offer services of conversion where needed, but where other document formats are supported, and specifically in cases where other document formats are expected or asked for, there is not a required conversion to CCDA 2.1. Dave, anything else to add on any of these points?
No, actually, it's fairly straightforward. As you said, like I said, we're moving to, hopefully people can hear me better. We're moving to may convert the documents if necessary, but that's it. Much softer requirement than before.
Perfect. Yeah, and you're a lot louder now, so hopefully that addresses the concern from before.
Great. Okay, let's go into questions. Enough people have said that I'm too soft, so I fixed it. Anyway.
Let's see. I'm just looking if there were any specific questions to query and retrieve. If the responding QHIN gets a document that is not a CCDA 2.1, i.e. a C32, and no conversion services are provided, can the content be passed on or should it be blocked? It should be passed on, especially if that's the format that was requested, but even if not, there's no requirement for the conversion. So if the initiating side, the query source, is not able to handle, in this example, C32s, they would likely need to have established something with their own QHIN for conversion when needed.
All right.
A couple of questions about some of the IACP stuff, which ties into these flows, but we'll get into some of that specifically later on.
All right.
So let's move on here. Message delivery. So this is the other transaction. Message delivery is one step, opposed to the 3 steps for a query. Again, the standard specified in the middle is QHIN to QHIN, and that is the IHEX CDR, the IPI 80 transaction. This could be any number of transactions, again, between or within a QHIN, between a QHIN and its participants and sub-participants, whether it's an XDSB push or your other forms of provide and register messaging, XDR, direct messaging. However it gets up to the QHIN then converts that into the appropriate XCDR message for sending it to any other QHIN, and there's an acknowledgement response that comes back. But otherwise, that is just a single transaction for proactively pushing a message from one source to a responding source. As far as the requirements here, the message source indicates who it needs to send the query to. The QHIN then determines where that needs to be routed based on information in the directory for the intended recipient.
I think the big thing to add to that is we only specify how it gets through the QHINs, and we only address it specifically to the HCID of the endpoint. So once it gets to the responding source, that is up to that organization to route it to the individual. That information may be in the documents, it may not be. However, that information is up to, or that final routing is up to the organization. There's a few questions. One from Linda Michelson: can the document be a V2 message? The document can be anything. A V2 message, a PDF file. Under message delivery, it's, we prefer that the information goes in CCDA format. However, if you have a specific need to send a V2 message or X12 message or any other form of information exchange, you can go ahead.
Yeah, and in the context of a query, the query source would know what type of document is available based on the second step, the document query. So that returns back a list of documents along with metadata for each document, and it would tell you which documents are XML documents, CDA documents, or if there's like a plain PDF or things like that, that would be in the metadata. So the query source already knows before they retrieve the document what that document is going to look like once they get it back.
Are there standards around error handling of responsive if something goes wrong? Yes, we do follow the IHE error handling and use those error messages. So if you're fetching documents and only some of them come back, partial error, partial success message comes back. If none come back, that's a failure message. IHE defines what type of error messages are used, and we're following that absolutely.
There's a question, excuse me, a question here. If message delivery process outlined here matches what is currently done by APHL to route electronic case reporting data to public health, and that absolutely could be done with message delivery here. The flow of message delivery outlined in the QTF is very similar to how electronic case reporting through carry quality is already handled today, leveraging APHL for that routing. So that is absolutely a scenario that could be managed with message delivery.
It says, we expect QHINs to be able to handle all possible payloads for message delivery. By handling, they mean pass it on? Yes. If a payload is attached, obviously there may be size limitations. A QHIN may have issues around size. If you want to send an entire X-ray system or something sufficiently large in imaging, that may be a problem. But in general, whatever they receive should be passed on through the messaging system unchanged. Is this possible way to deliver lab results to clinicians from a lab? Possibly. Again, if the lab is connected and the clinician is connected, then absolutely that could be sent through the message delivery system.
Right. I see a few questions about how some of the SAML stuff works, some of the other transactions, and we'll get to all of that as we break down the sections of the QTF. So I don't see anything specific to just query or message delivery in general. So let's keep moving on here for now. Again, so we're going to jump into, so functions and technology to support exchange is the title of the largest section within the QTF, and we're going to just go through that largely section by section here with some of the high level requirements, not touching on everything necessarily that's there, but just some of the things we felt were important enough to put in the slides to cover here. And we'll see what questions come in or have already come in as we go through these. So the first is just the general base requirements, and that is that, again, at the QHIN level, transactions QHIN to QHIN are defined pointing specifically to the IHE ITI technical framework, revision 17. And so that is specifically one of the conformance statements and is what we link to in the QTF for all of those documents. For the XCPD, XCA, and XCDR are revision 17. And then there's a requirement for addressing any communication issues, both between QHINs, QHIN to QHIN, as well as QHINs with their participants in the shortest time possible.
That's the easy part. Now we go into the fun parts.
I don't see any questions on that, so that we can go on to certificates, and I think there were some questions here. So all certificates are X519v3 certificates, some specific requirements here with the modules that must be supported. There is some further detail here, and some more of this will be fleshed out as we define things with how the directory will work and the RCE certificate authority, how that will work with certificates being issued to the QHIN. And again, this really only matters at the QHIN level. certainly there needs to be secure communication between a QHIN and its participants, which I think we'll get to on the next couple of slides. But there will be further definition around the certificates explicitly used QHIN to QHIN to ensure that everybody trusts each other and each QHIN can communicate with all other QHINs immediately once they get into the production environment. Can you explain that all certs must be sourced from the RCE? And is the RCE planning to become a certificate authority? So this will very likely mirror what we do in carry quality today, which carry quality has actually two CAs technically that everybody trusts the certificate authority root and intermediates for. Direct Trust is who actually manages that on behalf of carry quality and manages issuing the certificates, but it is everyone has a certificate issued from one of those two CAs, and everyone is required to trust both of the CAs. So there's no, just widely trusted or whatever other certificates in use. It ensures that everybody is able to immediately communicate with everyone else in the directory, or at least make that server-to-server communication, because everyone is using certificates from that trusted authority.
All right.
So secure channel mutual server authentication, we do specify that QHIN to QHIN transactions must use TLS 1.2 or above, and I expect that there will be timelines and requirements for moving to 1.3. In fact, we have a when it must be supported and must be prioritized. There you can see in the last bullet, and that's based on just the timelines for 1.3. But for now, it's required 1.2 or above. There was a question earlier on about the reference to OAuth 2. OAuth, we expect, could be used particularly in the case that a QHIN within its own network allows its participants to communicate with it using FHIR. And then it translates to the appropriate XCPD, XCA, XCDR, etc. And so that would need to be done with an OAuth 2 connection from the participant up to the QHIN. Since we're not doing anything with FHIR QHIN to QHIN today, certainly we'll get to that in the FHIR roadmap, but there wouldn't be any OAuth QHIN to QHIN today.
The big things is we are, requiring all of this to conform to Pub 800-52 Revision 2. With the exception, we've eliminated 3 extensions: the extension client certificate URL, and then the 2 for 1.3 early data indication and 0 round trip resumption. While those are minimal impacts to security, it was just felt that with the quality of information going through this, it's just far too much of a target. So anything that reduces it even a small amount should be resumed or removed. There we go. So that's the big things is that trying to make this as secure as possible, both between QHINs and of course between a QHIN and its own participants. And then of course use of TLS 1.3, as Alan said, should be prioritized before January of 24, and after that must be prioritized from then on. And as things go on, we'll probably upgrade that requirement.
Yeah, and a question just came in about what does it mean to prioritize TLS 1.3? Is it required? And the prioritize is referring to at the server level. The server prioritizes making the connection of 1.3 before it falls back to 1.2. So we're requiring that the server prioritize 1.3 before it falls back to 1.2 by January 2024, just in alignment with other TLS 1.3 rollout and requirements. And we will very likely at some point update to then remove the allowance for use of 1.2 whenever other TLS requirements also move to that point.
We have a question. In several in several years, does that mean Firebase QHIN to QHIN exchange need to use SAML for authorization and authentication instead of OAuth? We haven't specified how fire exchange between QHINs will be done. Right, likely, no, we will not require that. OAuth will likely be the priority, but that has to be decided as part of the next versions of the QTF.
Yep, more to come on that one, definitely, with the fire roadmap. I think that's everything specific to that topic. So let's move on, and that one, that previous question ties into this one a little bit, just about the use of SAML. So we do define the use of SAML tokens in each of these transactions, and the QHIN will sign the SAML with its QHIN certificate, persisting all of the originating user, organization, all of the information that's otherwise included as the SAML attributes. We define some of the ones that are specifically required to include, and there was a question earlier on of if a participant or sub-participant is using, for example, an XDSB connection without SAML to communicate to the QHIN, how would the QHIN know this information? And that is one of the flowdown requirements, that the QHIN has to ensure that it has this information in order to either pass through or create a SAML token on behalf of its participants and sub-participants. And so there would need to be, if that information is not currently passed in whatever method of communication gets the transaction up to the QHIN, that would need to be modified so that the QHIN has the appropriate information to make the appropriate SAML token.
Okay. Could you please elaborate on QTF 026 QHINs must specify the mechanism, i.e. format and content by which participants transmit authorization? That is directly the flow down, where in order to ensure that the information is set, QHINs have to specify how it's going to be done. So as part of the negotiation process to onboard a participant, part of the contracting will need to make sure that the QHIN has the information to populate a SAML if SAML is not being used.
Yep, and then we've got another question about the conversion or whether conversion is needed. Are they required to convert from FHIR to CCDA if both sides of the connection support FHIR but are QHINs? So again, we're not doing anything with the QHIN FHIR for the technical transport today. That will be detailed as we get into some of the details of the FHIR roadmap and what's planned there. QHIN to QHIN, the transport is required to use IHE, XCPD, XCA, and XCDR. The payload absolutely could include FHIR resources or bundles. Again, that information would be included in the metadata of the transaction for the query source to say, yeah, I support pulling in, this FHIR bundle, and I'm going to ask for or query for and retrieve that FHIR bundle. So FHIR as absolutely could be passed QHIN to QHIN. It would just be passed as payload to an IHE transaction. Where can we find the FHIR roadmap info? The FHIR roadmap is available on the RCE website, and we've got a slide. We'll talk about it a little bit here after we get through the rest of the QTF stuff. Who will sign the SAML assertions, the QHIN or the requesting source? The QHIN. It is the QHIN that has the certificate, so it is the QHIN's. It's the QHIN's certificate that signs the SAML.
All right. Looks like the questions have slowed down for this one. Let's move on next.
Yeah. So next we have exchange purposes. So as you're likely all aware from having read the common agreement as well, it's a much longer document. I'll forgive you if you haven't gotten through that one yet. But we have 6 defined exchange purposes, and these are all in alignment with what had been proposed previously. And these are all supported for exchange. 2 of these are intended to be required for response initially, and those are treatment and individual access services. The others, payment, healthcare operations, public health, and government benefits determination, will all have some additional detailed clarification around how those are used and some of the requirements there in specific exchange purpose implementation guides or exchange purpose SOPs. But each of these are allowed today and to be used for any of this QHIN to QHIN exchange with query or message delivery. Two related questions just came in about commercial benefits determination and whether insurance companies can participate. The decision today was to limit that definition of government benefits determination really to government benefits determination. So that would include things like Social Security Administration, disability claims adjudication, for example. Does not today include life insurance. However, a life insurance or others even who aren't necessarily included in here could potentially make an app available to a patient, have the patient request the information, leveraging individual access services, which I know is something that organizations are doing today in other contexts as well. But they would not be able to leverage the government benefits determination purpose as it's defined today.
Now we're getting lots of questions coming up here.
You state the word must respond to a request. What are the penalties, if any, for slow or no response to a query? Well, you're required, and so the penalty would be in alignment with any other requirement that you're out of compliance with, including and up to suspension. Now, I hope that you wouldn't be suspended just for having a slow response time, and some of that will need to flesh out as far as interim penalties and enforcement. There is a defined process for dispute resolution. If an organization were to bring a dispute like that up, that someone isn't properly responding, and that would likely go through the dispute resolution process. But anything throughout the common agreement, the SOPs, the QTF, that are required are contractual requirements. And so there would be penalties if an organization is not fulfilling those requirements.
Okay, getting a number of questions regarding access. Individual access services on the bottom of permitted exchange purposes is for patient access. So individuals requesting their own information. That is part of the first set of exchange forcing requirement, forcing response. There's a lot of questions about how payers perform queries. QHIN, a lot of
questions coming in just about where people would fall. I mean, what about a payer or patient access? Payer would use the payment exchange purpose. Patient access is that individual access services. That's what that means. How do payers perform queries leveraging the payment purpose? No, they would not be treatment or individual access services. They would be payment. Can public health agencies participate in the QHIN? Absolutely. They would, if they were initiating queries, such as for a case investigation, they would leverage the public health exchange purpose.
Are the response requirements flow down requirements? We don't have that authority. We can only state that a QHIN must respond to it. How a QHIN sets it up with their individual participants is entirely up to them. However, we would expect that if a QHIN is required to respond, then they would make sure that all of their connections would be required to respond. Questions are coming in very fast.
Yeah, lots of them on this one. Would not responding be considered info blocking? I don't know that we're in a position to say yes or no on that definitively. I think the answer is it probably depends, but potentially. Again, just based on the context and the exceptions for information blocking and what the request is, etc. So not responding certainly could implicate information blocking, but that's going to be outside of the context of what we define. We don't define in TEFCA what is or is not info blocking. We point to the info blocking regulations. So that's absolutely something that would need to be considered if you were not responding to anything.
There's a lot of questions going on that really are CA questions about flow downs, about, you know, things like that. We would suggest you ask those in CA CA presentation. We can't answer them here.
How are patients supposed to access, if not through apps that typically use APIs? They absolutely could use apps that use APIs. Those apps could be provided by a QHIN, by a participant, or by a sub-participant. Could be just individually be a participant or sub-participant, and then would send messages up to the QHIN for translation and transactions over to the other QHINs. But we absolutely anticipate that there will be patient apps participating underneath QHINs, or even provided by QHINs.
I think we better move on before we get too hip deep in legal issues.
Yeah, sounds good. Yeah, lots of questions still coming in, so we'll see how much time we have at the end and circle back on some of this one. Yeah. The next is around patient matching. So QHINs are required to be able to resolve requests using the demographic information that comes in. How that actually happens will likely vary by QHIN. QHINs, participants, sub-participants may have, there may be, in the second bullet examples here, an enterprise master patient index, an EMPI at the QHIN level. So a QHIN certainly could receive ADTs, for example, from its participants and build out a master patient index of all of the patients represented by any of its participants. And the QHIN manages the initial step of patient discovery to determine whether any of its participants knows the patient. That could be done using a record locator service or other means, including federating queries. The QHIN could pass the queries down to its participants and ask them to determine whether or not they know the patient. In any of those techniques, the QHIN would need to ensure that it's able to meet SLA requirements. I think where that becomes most of a concern is if the QHIN is passing the transaction down to its participants to respond, then it would need to have appropriate SLAs between itself and its participants to ensure that it's able to get a timely response back from its participants to get that response back to the other QHIN. The demographic information we talked about in some of the previous questions, and then we'll certainly be doing additional work with QHINs in the future to improve patient matching recommendations and requirements in the future.
Again, this is where we look at use of the USA technical specification. The flowdown says it should be used by the responders. However, if it's not used, it has to be normalized to that specification by the QHIN. So when you're doing, patient matching, please follow that information so that the person to match it has the best quality information or the best quality formatted information to match with. Had a couple of questions, what information should be used for a match that was asked earlier. The short answer is everything they get should be used for a match. However, your system may only use specific fields or whatever it is. The only thing that does flow down is that when a request for patient information hits, you are not allowed to respond with please send more information, because by definition everything that can be sent has been sent that falls within USCBI v1. More questions. Would a geospatial fan-out approach classify as an alternate innovative approach for patient identity matching? It could. The whole issue is, as long as everybody has, has a way of responding within the time necessary and can get all the information about a patient available to that QHIN. How that comes into being is up to the QHIN and how it's done. Specifically, doing it within geospatial and doing it at that level may have issues meeting SLA requirements because of the number of organizations that would need to respond within the SLA time limit. Can QHINs return candidate match or single best match? That's a policy issue for that organization. I think that's.
Yeah, I think that's most of the patient matching. I was just looking, there was another question about Project USA standards, and yes, we do point to that for address. So definitely want to take a look at what's required there.
Yeah.
I think that's about everything. And sorry, we'll certainly go back through the questions as we have time at the end. There's a lot coming in, so apologize if we skipped over one. Next is the RCE Directory service. So the RCE will maintain a directory that includes information about QHINs, their participants, and sub-participants to appropriately route and find organizations for sending and querying. There are a number of requirements for how QHINs are expected to interact with that directory service. Excuse me, for example, they need to maintain a local copy, and we specify that it needs to be updated more often than, or no more often than once per hour, and no less often than once per day. So each QHIN is, and then there are some timelines for, as there are updates to participants and sub-participants, how those get made into the directory. This is a FHIR R4 organization and endpoint directory that will be available to the QHINs, again, for all of that lookup, with some requirements around, even the level of facilities of their participants and sub-participants that need to be published for being able to look up and do some of those, radius-based searches and things like that, based on patient information or demographics that are available.
Let's see. Will the RCA service follow the same structure as care qualities?
Yes. Will there be an implementation guide for the RCE directory? Yes. We point to, in the QTF, we point to the when it's available RCE directory service implementation guide. That directory is, we're working on the process and documentation for that directory right now, based on ongoing work to move care equality directory to an R4 compliant version.
All right. Participant can participate more than one QHIN? No. Participants are supposed to be hooked only to one QHIN.
Yep. Yeah, and that goes to another question just came in of if the directory includes I guess I read it as participants. If the directory includes patients as sub-participants, the directory would not include individual patients. It would certainly include IAS service providers, which could be a patient app, but its individual patients would not be represented in the directory.
All right. Does the RCE intend this section to mean that the home community IDs in the directory will need to be unique? Yes, it would. They would need to be unique, otherwise routing becomes questionable.
Right. Yeah, and that goes back to one of the previous questions. A participant or sub-participant can't simultaneously connect through multiple QHINs. You can be connected once, and in fact, there shouldn't be any reason that you would ever need or want to connect through multiple QHINs, because you connect once and get access. That's kind of one of the fundamental points of why we're doing all of this.
Yeah,
Hey, Alan and Dave, I wonder if I could address a question that's come up a bunch of times and it might help folks. I've been trying to field some of the questions that are not necessarily QTF related just to be responsive. Is this a good time to interject?
Yeah, absolutely. Go ahead.
Yeah, so it doesn't necessarily directly relate to the directory service, but I think there was a question that sort of drew a corollary to it. So there have been a number of folks who asked, how many QHINs are we expecting to onboard? And, we've typically said at least 2, less than 100. We anecdotally have an estimated number in mind, but it really depends on how many players come forward that have not publicly already stated their intent to pursue designation. So anyway, I would say it's probably an order of magnitude closer to carry quality, in terms of the number of implementers to QHINs, possibly fewer, but, we won't know until we kind of get further into it. So I just wanted to clarify that one.
Yeah, thanks, Marianne. Yeah, absolutely at least 2 needed. One QHIN can't do QHIN to QHIN exchange without someone to exchange with, but there's not necessarily an upper bound. Carry quality currently has 30. I think we've got 34. We've had a couple new organizations move into production recently, but implementers in production with another 12.5 or so at some phase in onboarding. So, probably in a similar ballpark, though not everybody that's an implementer in carry quality will necessarily qualify or even want to be a QHIN. They may choose to be a participant under someone else's QHIN. So, probably in the realm of more on the side of lower double digits than getting up toward 100, but not bounded. Can you supply an information source for the USA address standard? Yeah, I think
it's footnoted in the QTF, yeah. So you can find it in there.
Yeah, that was put in chat 20 minutes ago or so. Maybe we can stick that back in there if anybody needs it, but it is referenced that URL is in the QTF as the footnote when we reference the project USA standard.
Yeah. I think we can skip forward.
Yeah, let's move forward. And I guess just one related last question here. Can a participant move from one QHIN to another? Absolutely. That would just need to be coordinated so that the directory information is either deactivated when the new entry is activated or potentially even moved if it's the same identifiers. It could theoretically be moved from one QHIN to another as the managing organization. But that is absolutely possible.
Yeah, and we have requested that those kind of changes are sent to the directory service 48 hours in advance of taking effect.
Yep. Okay, so let's move on to auditing. This one's another fun one. I expect we'll probably get a lot of questions on. So we point to the ATNA standards for auditing with some additional specific data and record location defined as tabled here on the slide. This is right from the QTF. And we do specify that this is all QHIN to QHIN transactions, and then transactions between a QHIN and its participants and/or participants and their sub-participants need to be appropriately represented and logged for auditing.
The biggest thing is, we have not set a retention period. We don't expect you to retain it forever. We do expect that you will retain it for enough period of time so that in case of requirements that some kind of investigation has to go through, that the audit logs will be available at the QHIN level. We do add these items mostly so that we can track where through the QHIN, the ring of QHINs, each of the QHINs that are participating is logged at each step. We've had questions asking what role the QHINs would have. Those follow straightforward using the IHE roles of responding or initiating a gateway. So each one will do it that. And of course, we do have the flow down for E2147-01 for flow down. That's to set a minimum standard. If you can use the ATNA standard, so much better. I know in Fire, I know in most systems, the ATNA standard or a variant of is used. But at the very minimum, the ASTM E214701 is required.
Perfect. And I know we got a question ahead of time about this one, just about so the QTF has some comments around when things are expected to likely be audited for success scenarios versus fail scenarios, but ultimately we point to the ATNA standard. And so there was a question about when is it expected or required that a QHIN would maintain in its ATNA audit logs PII or PHI, and what the minimum is there to be compliant with the ATNA standard.
Getting a lot of requests about access to the audit logs. Those are specific policies of the QHINs or their participants or sub-participants. The RCE should not have direct access to them, but may need to request as part of an investigation, which is why retention periods are important, but not yet specified. As such, it will be up to a QHIN to decide who has access, but audit logs tend to be completely secure and private and require more than one step to get to, usually several steps and authorizations to access an audit log. So I think that's the big one. I think, Alan?
Yeah, and then as far as the requirement or the minimum requirement of what must be stored and whether a QHIN would store PII or PHI, especially in the context that QHIN otherwise doesn't store any of that because they don't have an EMPI and pass the queries down to their participants. ATNA doesn't specifically require that any of that information be audited. It's more the fact that the transaction occurred, who the transactions were between, and storing in the context of a document exchange, storing the document reference, but not storing the entire document itself or even the demographics for an XCPD.
Will participants such as an HAIE who may be a member of a QHIN, will those audit logs be available to them upon request? That would be a contractual arrangement between the QHIN and its participant. I think that's it for now. Move merrily on.
Okay, yeah, that looks like all of it on that one. So some of the constraints for query or message sources and responding sources. Now this may be, and this section is actually one that we renamed. If you're looking or comparing between the draft version and the final version, we previously referred to constraints for participants and sub-participants, but there are certainly cases, such as when the QHIN is housing an EMPI, that the responding source is actually the QHIN, not necessarily a participant or sub-participant. So we retitled this one. It is constraints for query or message sources and responding sources, which would be the QHIN participant or sub-participant as appropriate based on whoever the message query source or responding source is. So a few of the things that are called out here is that sending only one identifier for a single patient in response to a patient discovery query. So if a patient has multiple identifiers, I know that especially within like a health system, there may be an enterprise ID and then a hospital-specific ID and various other IDs for the patient. Only one identifier per patient should be returned or shall be returned. Should leverage CCDA 2.1. Again, that's not required, but we do point to it and recommend. And this specifically also points to some of the guidance that came out of a joint Care Equality Commonwealth work group. There's a white paper that was published that we point to for some additional recommendations beyond just the CCDA companion guide. Responding course, not responding with a request for additional demographics. Dave already touched on that one. And then handling of IACPs, and there will probably be some questions there, but let me jump to the next slide because that's where we get to some of the IACP specific stuff. So there are four defined OIDs for representing what type of document is being asserted. In an IACP, this is an instance access consent policy. So this is where an organization could assert that they're doing a query and they have an access consent policy on file, and here is the appropriate OID for the type of document that is available. The responding side, the responding source, is able to go back and retrieve that consent document if that is something that they need to see in making a determination before they respond and release information.
Now, we picked these three formats because these are the ones that are out there most, whether it is in XACML or the FHIR consent resource or Cantera's consent receipt formats, or of course just a scanned PDF, which may require a human being to look at it. But all of these will be made available. However, whether it is for a single instance or it is a blanket access consent policy, these need to be at least considered as part of the data release information when it has been declared that one is available.
Right. Can a responding gateway respond with multiple assigning authority and associated patient identifiers? And per patient, no, it is one. Now, in the context of, for example, a QHIN is federating queries down to its participants, and there are 3 different participants who all know the patient, they would each return their own patient identifier, assigning authority, and home community triplet that the QHIN would respond with. And so you would have 3 identifiers because there are 3 different sources who all know the patient. But from any given source, there should only be 1 identifier per patient. As far as the OIDs here, only the OID up to 7204 is registered in the OID registry, where the others registered. They're not. They're extended off of the registered OID, which is pretty common and what you'll see with a lot of the home community IDs and assigning authority IDs and things that are used in transactions.
All right. We're running low on time, so we better skip forward.
Yeah, let's move on to, I think that was actually the last section of the QTF. So that brings us to the FHIR roadmap, which you can see some of the details of here. So as we talked about, the QTF today does not use FHIR for exchange QHIN to QHIN. It is all those IHE profiles that were defined, though as we discussed, in the current state, FHIR can absolutely be used within a QHIN's own network. It would just be translated by the QHIN to the appropriate IHE standard, and FHIR payloads can absolutely be exchanged. They would just be payloads exchanged over the IHE transport. The FHIR roadmap does outline a couple of stages for progression. For adding in FHIR-based exchange and some of the work that will be needed to allow QHIN to QHIN and even participants or sub-participants from one QHIN communicating with those of another QHIN as we move forward and expand to include FHIR. The main, you'll definitely want to take a look at the FHIR roadmap. It is a separate document on the RCE website that this graphic and the stages come from, but it gives a lot more detail about the individual stages and what's included. That's not the purpose of this webinar, so we probably won't get into a whole lot of the details here because we've still got a whole lot of other QTF questions to get through in the last 15 minutes. But the main takeaway is that we will be, in 2022, launching some work groups to develop what all of this ultimately will look like. The planned stages in the FHIR roadmap are planned. They are anticipated of what we expect this could look like. but we're really going to need to work with the industry to flesh out how to really get there, and what, the appropriate timelines, and even modifying what we've proposed if some of it just doesn't make sense. So those work groups will be starting up here later this year to define what the timelines and requirements for updates to the Common Agreement and QTF to add in FHIR-based exchange.
They've all gone quiet.
Yeah, not a whole lot of questions. Let's just, I guess, wrap up. There's only a few more slides here, so let's wrap up some of this final content, and then we can spend the rest of our 14 or 13 and a half minutes here going through as many of the remaining questions as we can. So how will TEFCA be operationalized? We talked about initially some of the application onboarding process. There are a number of educational opportunities, including today, that you're all here, with more of those to come. So you're definitely going to want to check out the RCE website for that, though the registration for each of those events, and more will absolutely be added. We'll likely be adding some office hours times as well to just get through all of the additional questions that we're not going to be able to get through today or on some of the other webinars that have already happened. The application process will look like this. Again, this will be defined in the onboarding and designation SOP that is soon to be published. We're working on finalizing that now, but it defines the process for a potential QHIN signing the common agreement, working with RCE to go through an application to ensure eligibility. That application is going to be based on the eligibility criteria in the common agreement. So again, definitely take a look at those. And then it moves into an onboarding process, which includes some testing, technical testing, validation with a test tool, and then between other QHINs in a stage environment before moving into production for some final production validation, and then receiving official designation and countersigned common agreement. A number of resources available on the website, number of events that are coming up. Like I mentioned, more will be added to the website as those are scheduled. So definitely keep taking a look there. And at this point, that's all of our slides. So let's take a look at some of the rest of the questions. And again, apologize, we're not going to be able to get through all of the questions that we received today. We will capture all these questions and hopefully address more of them in other webinars, or potentially even some dedicated office hours just to go through questions, but we'll get through as much as we can.
All right. So many questions.
Yeah, so started just kind of jumping up to the top, looking. I know there are a few that we addressed in around certificates in specific sections. How is data provenance maintained? That is absolutely something that in some of the CDA, the CCDA guidance documents we point to, there's some outstanding work that is being done around provenance as an element within both FHIR and CCDA. As far as the documents themselves, it's going to come from a responding source and have identifiers of who the responding source is, and so that should all be able to easily be maintained. Where it gets a little trickier is once data has come from one source, reconciled into another source, and then reshared, then some of the provenance gets more complicated. And that's where there is other industry work going on that we point to and will continue to point to for handling data provenance.
How will end-to-end encryption be maintained if a QHIN receives a message within its network via REST and then has to use IHE transport to send another QHIN? The end-to-end encryption won't be changed at both ends, whether they use OAuth or straightforward TLS and SAML. The encryption will be maintained. So at no point within the exchange between the participant and the QHIN, or the QHIN and another QHIN, or a QHIN and a participant, will it ever be unencrypted. So that's the end-to-end encryption will be maintained within a QHIN. That is up to how the QHIN will manage it.
Great. Can you explain identity proofing and how it is in compliance with IAL2? So there are a few different pieces where identity proofing could certainly come in. Some of that, as far as individual access, we'll need some further definition in an individual access service SOP for what's required there. IAL2 will likely play into QHINs getting certificates as well, if that matches the process that we have today, where the QHIN would be IAL2 verified for getting its certificate. I assume you're probably referring to the individual access piece more likely. And again, some details on that one and some of the requirements of individual access service providers to verify patient identity, so that responders know they're responding about the correct patient, will be in that specific SOP.
How does a QHIN know which other QHINs to query? If it is a targeted query wherein the home community ID of the desired information is known and specified, that can be checked against the RCA Directory, or more likely the QHIN's local directory version, and that will specify which QHIN to query. If it's not specified with the home community ID, they'll query them all. Following that, this design assuming every QHIN will have centralized MPI for associated with the QHIN's participants. No, again, it can be federated. So if they can maintain response times to the SLA standard, they don't have to have an MPI. They can leave that up to their participants. Does the RCA intent require identifiers received and next CP required to be persistent? No. Assumption 2A states that if they already know them, that they don't have to. So if a query has been done already and you already know that you want this patient from this HCID identified by this assigning authority and MRN, you can simply state that. So you don't have, as long as the query is known exactly what you want, you do not have to query for that patient.
Yeah, let's see. I think some of these, I'm trying to scroll down past any of the ones that we already addressed. Can you expand from public health perspective how participating in QHIN can be helpful? Access to patient data. I mean, being able to, again, message delivery for electronic case reporting or other types of submission-based events. Public health being able to send queries, such as in a case investigation or other information. Access to immunization registries potentially. Whether housed by public health authority or not. So there's certainly any number of, and I think we have public health. We have on the website some use case, and I'm blanking on what we actually called them, but some documents around different types of stakeholders and the benefits. And I believe there is one or is one in the works for some of the public health stuff. I don't know, Marianne, if you want to chime in on that one, if that's a document that we have available.
Sorry, I was responding to another question. I don't know that I have anything really to add. This is to the public health use. Yeah, there's going to be definitely more work around the specifics of that. What we actually really would like to do is engage a group, of folks representing the perspectives of public health and working with the ONC and all the conversations that they've been having on that, and really, drill down into specifics around a use case. The great, thing about TEFCA is it's multi-purpose. It contemplates that there is going to be a need and value and importance in sharing information for the SIX exchange purposes, and it's really about delving into the details of how to make that happen and put it in practice.
Great, thank you. Continuing on here, can you match on a hyphenated name? Absolutely. Again, that's just going to vary. How that's handled would vary by the matching algorithm of the responding source, but I would expect that most should be able to handle hyphenated names. Does a QHIN only need to capture and transmit the purpose of a request, or must the QHIN also capture the status of the requester as a provider, for example? So the purpose, such as treatment being the purpose of the request, would absolutely be included in the SAML assertion. There is additional detail about the specific organization role. Even if it's coming from a provider, the SAML can have the provider's NPI in it. So there is definitely additional information beyond just the purpose of the request, but who is the organization or user even that's making the request.
Looks like we were better at keeping up with these than I thought. Scrolling down.
Yeah, does the RCE need to evaluate and approve a QHIN's alternate, quote, innovative method for patient identity resolution? We are not intending to evaluate and approve necessarily, but if there were concerns raised, especially if there were a dispute about a QHIN not appropriately handling patient identity resolution from another QHIN, that is absolutely something that could be looked at in that dispute resolution process, but not something that we're intending to require QHINs to submit their plans for approval.
Really great work. Congratulations. Thank you.
Nominal flow step 5 states each responding QHIN combines the responses from the responding sources and returns a single IHE cross gateway retrieve response to the initiating QHIN's initiating gateway. Will QHINs be permitted to batch responses for patients that have a large number of documents or for which the documents are a large size? The responding QHIN needs to send back a single response to whatever was queried for. This is a synchronous transaction. The initiating QHIN could absolutely determine how it passes down, especially if it's requesting information from multiple QHINs at once, and whether it aggregates that together in a single response to its participant, or whether it passes those down one by one as it receives them. But a single document retrieve request, for example, to a single responding QHIN would need to have a single response from that responding QHIN.
Considering broadcasts will be the norm versus targeted queries, what does the RCE expect the QHIN will need to support as it relates to the number of transactions? Millions. This will not, this will not be something that a small organization can handle with being QHIN. It will be expected that you will handle millions of queries for patient information, for patient lookups, for for everything that's going on, for document queries. So if you are thinking about being a QHIN, realize that you will need to handle millions and millions of transactions per month.
I believe we've actually even stated, David, this is Marianne, that it would likely be millions and millions of transactions a day.
Millions a day. Okay.
Yeah, absolutely. When you consider the volume of patient discoveries, far fewer documents being retrieved on a daily basis, but the number of patient discoveries will absolutely be high. Can a third-party mobile app developer join a QHIN? Absolutely. Again, what they do would determine the purposes for which they can exchange, but an app developer could absolutely be a participant or sub-participant under a QHIN, or even services offered by a QHIN. And I think we're running really low on time here. Not sure, Dave, if there were any last questions you saw worth addressing.
Yeah, just one. What type of controls are there around patient consent for exchange and data use? That is being handled directly through the instance access control policies, so that consent can be managed between organizations.
Yeah, and I'll just add on that one that the TEFCA doesn't add any additional requirements for collection of patient consent beyond what's required otherwise by applicable law. There are some requirements for individual access service providers and the consent that they must receive from their users, the patients, the individuals using their service. But we don't add consent requirements. We have a mechanism by which consent can be asserted when needed, but we leave the need for consent to applicable law. And with that, again, I apologize. There are several more questions that we did not get to, but we will hopefully have some office hours and additional webinars to address more of these questions. And I'm not sure, Marianne, if you want to say any closing remarks, but thanks everybody for being here today.
Thank you.
Yes, thank you all so much for the incredible attention, and to David and Alan for fielding many, many questions on the fly here. And again, we look forward to future meetings. And if you want to email other questions that come to mind, you can always email us at rce@sequoiaproject.org. We are tracking all of these. The questions that we were not able to get to today, we are logging. And so, as we mentioned, hosting office hours, we can sort of address those that we received in advance and do further drill down. So we really appreciate it. So thank you all, and have a great afternoon. Bye all.
Thanks, everyone.
Thanks all.